might be a patient who came to the med surg floor for, let's say, I don't know, asthma. The patient may still require a monitor just because, perhaps they have a history, maybe a history of atrial fibrillation or some other abnormal rhythm. So it is important for you to get at least a basic understanding of dysrhythmias so that you can properly and safely care for these patients. All right. Now, before I get into that, I wanted to touch on a couple of things. Yesterday in my 1640 class, apparently there was a few students who were left off my list. And so they did not get my emails about only completing roughly about 30 EAQs. And one of the students actually ended up doing the entire assignment or the entire EAQ. Now, this is just one EAQ. She ended up doing about 200 EAQs. All right, 200, because she didn't know. And I'm sure she's glad she knows now. So I added them to my email, of course, and inform them that they're only doing 30 EAQs. So that's just to let you guys know that you're very fortunate that I had the foresight to speak to my director of nursing, Director Cartwright. Sometimes I get her name a little mixed up, but anyway, the director of nursing. And she was in agreement. Actually, she told me that, because we had a conversation about this, and I said, well, I'm thinking about giving them at least maybe, I don't know what number I said. I think I said 25, 30. I think I may have said 30 EAQs. This was several terms ago. And she looked at me and said, well, why give them that much? Maybe 10 or something like that. But of course, I feel like you should do a little more at least and kind of get you more better acclimated to the questions that you'll be receiving. So she is aware that I'm giving, the 30 EAQs and not the entire 200 or 300 sometimes, or 150, or these astronomical questions, endless questions that you all will have to answer. So she is aware of this. I'm not doing anything behind anybody's back. I'm not doing anything unethical, right? They are aware. And I did that way back when because I wanted to prove to administration that students do not need to be doing all these EAQs because they're not reading, and that was a fact. And that played into them not doing well on their HESEs as well as the NCLEX. Hence the biggest reason why we are not where we're supposed to be as far as NCLEX pass rates, because students are not reading. And so I'm thankful that I had the foresight to open my mouth and mention to them that, listen, we need to minimize these EAQs and encourage the students to read. When I did that several months ago, my numbers continue to improve. All right, so I must be doing something right. All right. Now, and I had a couple of students who felt like, I'm not grading the EAQs timely. Now remember, your first EAQs were due on Monday. If you think I'm going to sit down and as each student completes an EAQ, I'm going to keep going into the EAQ system and updating them, I'm here to tell you, you might as well toss that thinking aside because that's not going to happen. All right, I'm telling you right now, I'm on a recorded thing here on Teams. It's not going to happen. All right, it's only been since Monday. All right, that's only 2 days ago. 2 days. It will get done. I have said this before, all of you, that I want you to do 30 EAQs, knock off, and you'll get full credit. If I don't follow through on that promise, then you all can go to administration and say, he said he would do thus and so, and he didn't do it. And so we have these failing grades, and so he should be held accountable for that. I don't have a problem with that, because if I lied, then I should be held accountable, right? You should tell on me, right? You should report me. But if there was ever a time I said that I would give you these grades and that didn't happen, I wish somebody would speak up. If it's something you heard or something you experienced directly, please let me know that I didn't follow through. Because whenever say again?
Excuse me.
Yes, ma'am.
I just want to clarify, because I thought you said 20 to 30. So you want us to do 30?
No, it's 20 to 30. I'm sorry. Yeah, it's 20 to 30. Yeah.
Okay.
Yeah, that's fine. Yeah, so if I didn't follow through, then give me the date and time and the individual wherein I lied to them and it just didn't take place. And I can assure you that didn't happen. Now, let me explain this one to you also, if you think this is grade fraud. So you know how when you do, let's say if the system makes you, if you're leveling up and the system makes you do, let's say just to make it easier to explain, let's say if the system makes you do 100 EAQs and you get 10 wrong, right? We set the system actually to pass fail, because in other words, if you complete that assignment in that way, it is set up. Well, first of all, if you get 90 out of 100 correct, what would your grade normally be? Can anybody tell me? Just do the math.
90.
Yes, because they would be worth a point apiece. But you know what grade we give you? 100. Is that grade fraud? The system gave you that grade, so it's not grade fraud. You did 100 questions, you only got 90 right. You should get a 90. And actually, I can set the system up like that. But I choose to set it up as a pass-fail. So if you complete the number of EAQs I tell you to do, then you get the 100%. If you don't, you get a 0. All right, so I think that's more than fair, right? But this preposterous idea that I'm committing grade fraud is just, anyway. But I just wanted to explain to you that no grade fraud is being committed. And if you want to know who I got this permission from, actually, Dean Wright, I'm sorry, Director Wright has encouraged other instructors to reduce the number of EAQs because the students need to read. So if you have an issue with it, you can take it up with her. All right? Don't take it up with me. Well, all right, let me back up. So as I mentioned to you earlier, the EAQs were due on Monday, right? And I think a case study was due Saturday. I was off that entire time. I was on a mini vacation, right? I do deserve some time off, by the way, even though I did attempt to work when I was in Jamaica, but I couldn't access my email. So anyway, however, if you don't like my methodology, as far as when I get to the grading, I got a solution for you. If you go ahead and level up and complete all of the EAQs, it might be 100, it may be 150, it may be 200. But if you complete all the EAQs, it is going to give you an immediate grade. Now, you can either do it that way and do 100, 150, 200 EAQs or more, but I can assure you, you wouldn't be doing much reading or you can just do the 20 to 30. That's up to you. All right. If you do it, the 20 to 30, it is going to take a little time. Be patient. But if you just can't wait, you know, if you just can't wait, then just go ahead and just sit there and just click and 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 do them all, and you get an immediate grade. And guess what? Nobody would be mad with you. Seriously, would anybody be mad if somebody decided to do all the EAQs and do 150 to 200 EAQs? I wouldn't be mad. I might even commend you. If you got the time to sit there and do all those EAQs, then so be it. You know, I wouldn't stop you, but you will get an immediate grade. You don't have to wait on me. My job consists of more than sitting here and entering grades. That's just a small part of my job. It does get done. All right. I have other things to do. I have almost 40 students. All right. Got about 30, I think maybe 31 in 1640, and I think, well, about 8 or 9 in this class. So things don't happen pronto. That's not the way life is. Things take a little time. If I am patient with you, I would expect that you would be patient with me. If I told you that I would give you the grade, I would give you the grade. All right. This is being recorded rather at the moment. And so if you want me to send this to an administrator, if I decided to go back on my word and you send this to them, then we'll see who will get jammed up, and it will be me, of course. But I can assure you, if I promise you that you would get the grade, you would get the grade. So I would appreciate, and I will be sending out an email to this to speak on this. Please do not send me emails badgering me about why grades are not put in. Don't do that. I got a lot going on, and I don't need that extra stress on me. And I will tell you that I will tell you again. Well, actually, the fact that I'm telling you now, and when I do send that email out, of course, but the fact that I'm telling you guys now, just know I will not respond to that particular question because it's already been asked and answered. All right. So I can't keep going back to the same things, folks. We have a lot to do. This is a very complex course to teach, and I need all the energy I can to teach it. All right. So I don't need that extra stress. So if you're stressed about it, then find a way to deal with it. All right. But don't convey your stress to me. So it will get done. Don't worry. Nobody's failing. We haven't even had the first exam or quiz yet. So just be patient. Hold on. Focus on what is necessary. You want to get through this course? Focus on what you have control over. All right. That's all I can say. All right. So without further ado, we will jump into the lecture.
Dr. Weaver,
Yes, ma'am.
this is Mary speaking. I just wanted to let you know that I don't have on my uniform top because I caught a flat tire, so I wasn't able to make it home yet. So I'm
Right.
just sitting in my car doing, on Teams right now until I can get home.
And you said this is, all right. I'm sorry, what did you say your name was again?
Antonaria.
All right, I see it. I see it. Yeah. All right. You can just remain off until you get home then.
Oh no, I'm gonna still be listening.
Oh yeah. I know. But you can just remain off until you get home and able to change. Yeah. All right. Well, I never did it that way. Let's see. So I will be doing a doing some examples for you guys so that you can understand what it is that we're going over today. Just so you all know, um, this is that day where you stay until 5:30. So we will be in lecture between now and 8 and 12:30, and then from 12:30 until 5:30 you'll be in clinical. And I decided to go ahead and do a virtual clinical, and so what we'll do is we'll be working on a concept map that I will give to you all to do on one diagnosis. All right. Yeah, you do it on one. Yes.
Is this going to be every Wednesday or just this specific Wednesday?
It will probably be the next two. Well, this one and the next two, because remember, you guys have to do it. I think somebody correct me if I'm wrong, but I think it's 3 Wednesdays. You have to do this in order to make up, I guess, the 15 hours that you need for your clinical.
Okay.
Now, let me say this. Let me back up when I say that. So next week is going to be your first exam. So that will be on campus on Wednesday morning. So because it is an exam, if it was a quiz, that's one thing. But if it's an exam, then you guys would be on campus on Wednesday from 8 to 12:30, and then from 12:30 until 5:30. All right. But then the following week, since it'll be a quiz, then it'll be back to virtual. So you just have to come back that one day to do the lecture and clinical, and that'll be next week only.
This is Melissa. I have a question.
Mm-hmm.
What time are we going to take the exam? Because you said 8 to 12:30. So are we going to get started immediately with the exam at 8 a.m.?
Yes. Yeah, it'd be just like if you all were coming to class from 10 to 2:30. We will start the exam at 10 o'clock as usual. So this is the first time they've done this. Where you come to class really early and you go right into clinical after a lecture. So, but it's just three times in the term. So,
Dr. Weaver.
Yes.
So just to clarify, so we're online today. Next Wednesday we come on campus for the whole 9 hours, and then the following Wednesday we back online. Back virtual for that one Wednesday.
Right. Because they want quizzes done on campus. I'm sorry, they want instructor exams done on campus. Right, instead of virtual.
So after the exam, will we go home or will we go into a clinical lab?
If you come to lecture on next Wednesday at 8 o'clock, you'll do the exam, and then we'll go into lecture in one of the rooms, and then you'll go right into clinical at that point. All right. So, yeah, because, if you're on campus already, you're on campus. So it's no sense in anybody going home, especially Miss Williams, I believe, who lives in Savannah. If I say everybody go home, that means it'll take her 2 hours or so to get home. So it wouldn't make sense to do it that way. So that's why we typically just find a room and, do our didactic, and we'll do our lab, and then we're done. I don't know who's going to be in the lab, so I don't know if we're going to even be able to get the lab. So, but of course, we'll have to find something to do. Any other questions? All right. So in dealing with the heart, the heart consists of course, the heart muscle, and it also consists of an electrical system. All right. It is our electrical conduction system, which consists of the SA node, AV node, bundle of hairs, the right and left bundle branch, and then your Purkinje fibers. That's your electrical system. So we have muscle, electrical, right? So they both work together. The electrical system starts off first in sending the impulse, which we'll get more into. And then the heart muscle responds to that electrical impulse and gives us a contraction. When it gives us a contraction, when it gives us a pulse, it is essentially giving us a blood pressure. It is giving us a pulse. We call that mechanical. So you have the electrical, and then you have the mechanical. Now, so we know that the heart is an intricate pump that perfuses the entire body. Without the heart and that network of blood vessels or the arteries throughout the body, we could not get blood or that perfusion to the rest of the body. All right. So you can actually have an electrical activity, and I think I've explained this to you all. You can have electrical activity that's possible without mechanical activity, but that is a condition. That condition is called PEA, pulseless electrical activity. In other words, you have electrical activity, but you don't have a pulse or blood pressure for that matter. And that's the condition. I believe it's like 8 different conditions that can result in PEA. Had a family member who just went through that. Well, my sister's family, whatever. In that particular case, you do not have a pulse. And one of the reasons why, even though we're not studying that particular rhythm, I always mention that to my students, because if you're working in a hospital and a patient is on a continuous monitor, cardiac monitor, and sometimes they have these monitors sitting in a central location, and you have also the monitors in the patient's room in both places. All right. And so if you're sitting there charting and you're looking up at the monitor and you see this rhythm that looks like a normal sinus rhythm, you will say to yourself, well, my patient is alive because they have an electrical rhythm. That's not the case all the time. All right. And so if you have a patient who's showing a normal sinus rhythm, which is what I will show you, and it's possible for you to have a normal sinus rhythm, that means a P wave, a QRS and a T wave, and everything is right and normal and whatnot. Again, I'll show you that. But you can have a rhythm that looks like that, but it doesn't mean that you actually have mechanical activity. Remember, the mechanical activity means that you're getting perfused, you're getting actual perfusion. Electrical activity doesn't mean you're getting perfused. It is the muscles of the heart muscle that causes or brings about the perfusion, but it's stimulated by the electrical conduction system. So I say that to say this to you. You always want to go in your room at certain intervals to assess your patient. All right, so if you go in the patient's room, let's say you do your rounds every hour or whatever the hospital policy is, you do your rounds, you go into the patient's room, there's electrical activity on the monitor, you go, and because the patient just looks funny, maybe ashen in appearance, and you go to the patient and you check a pulse, and now you see that they're cold, right? Maybe even stiff. And so if you do that, the patient is essentially dead. All right, and this is why you must get in those rooms and put your eyes on those patients and make sure they are alive and breathing and have a pulse. Again, you can have electrical activity, but no pulse. Now, if this pump is broken, this heart pump, then perfusion to our tissues and organs are impaired, and then this will result in those organs having a dysfunction. All right. Now, cardiac dysrhythmias, and what cardiac dysrhythmias are, they're abnormal rhythms of the electrical system, which we will see. We'll see some dysrhythmias such as atrial fibrillation, atrial flutter, PACs, PJCs, PVCs, ventricular tachycardia, ventricular fibrillation, and so forth and so on. Asystole, flatline, right? So these are considered cardiac dysrhythmias of the electrical conduction system. And with many of those that I just mentioned, cardiac output can be impaired. All right, because depending on these disorganized rhythms, it will determine how well your heart beats. If that rhythm is too fast or too slow, it can impact your cardiac output. All right, anytime your cardiac output is impaired, then there's not enough blood that is leaving the heart to get to the rest of the body. And this is why the cardiac conduction system and the heart muscle is so important, because they work in concert to give us the blood that we need. All right. And so this is a life-threatening situation, of course, when the body is not being perfused. There's certain issues that can result in an abnormal rhythm. That is, for example, coronary artery disease, electrolyte imbalance, and also impaired gas exchange can lead to an abnormal heart rhythm. These are just a few things that issues that can lead to that. For example, with CAD, coronary artery disease, again, we're talking about coronary artery, all right? The arteries of the heart. And so these arteries brings blood back to the heart as it leaves the aorta, right? And so if you have all this plaque buildup within the coronary artery, then you get less perfusion going through the coronary artery. And if you have less perfusion going through the coronary artery, then that artery, which has the job of bringing blood flow to the electrical conduction system, is going to be reduced. And if that blood flow is reduced, that the tissue cells, the electrical conduction system will fail. And this is when you will see these abnormal rhythms. Now, also, as far as electrolyte imbalance, remember your cells depend on potassium going in and out, calcium going in and out, and, exchanging places. And this is what brings about a normal electrical and mechanical conduction or activity, if you will. And so if you have an abnormal electrolytes, then it can impair the heart, because the heart and the electrical conduction system, or which include the electrical conduction system, does depend on electrolytes, which is why, as nurses, we have to continue to monitor our labs, especially if you have a heart failure patient who is on Lasix or some diuretic that is depleting their electrolytes. So we want to make sure that we look at those labs, look at that calcium, that magnesium, especially that potassium, and we must either call the doctor or the nurse extender or whoever is available. We must call them and either get an order for some electrolytes to be administered, or sometimes they have a standing order in the patient's chart. And this is where it may say if the magnesium level or potassium level is between this range, give X amount of electrolytes, all right, infusion. I love it when there's already a standing order, and that way it saves a whole lot of time and steps. If you know that you have a patient on diuretics and that they're not on a sliding scale, so to speak, as far as electrolytes, don't hesitate to call the doctor, or if the doctor comes to the floor and say, hey, the patient is on Lasix, can we get a standing order? He or she might give it to you, or maybe not. But, save yourself some steps. They're going to be up there anyway. Ask. All right. No harm in asking. Now, as far as the impaired gas exchange that can lead to abnormal rhythm, just think about it. If you have coronary artery disease, remember, oxygen is carried in the blood, or if for some reason you have an impaired gas exchange, maybe you have heart failure and or whatever the condition is, doesn't matter. Whatever the condition is that will reduce your ability to exchange gases, right? Meaning now you have less oxygen getting to your heart muscle as well as the cardiac conduction system, and it will lead to an abnormal dysrhythmia. All right, so I wanted to go through each of these because, sometimes just talking about CAD and electrolyte imbalance and impaired gas exchange can lead to abnormal heart rhythms, and then we move on to the next thing, and students are wondering, man, I have to memorize this because they don't know why this is happening, and so I figured let's go through each one, and that way you'll understand, hopefully, why the conduction system, the cardiac conduction system, is being impacted, and therefore these patients will end up with cardiac dysrhythmias. Does anyone have any questions about this? All right. These are your objectives. Go ahead and take a look at these. At the end of our discussion, you should be able to respond intelligently to these objectives. Okay, so take a look at that. Does anyone know what this is? This device?
The defibrillator.
Right, it is a defibrillator. I don't care how much CPR you do, the most important device or tool that can be used in those instances when CPR or someone goes into cardiac arrest is this little device. Electricity is by far the most significant tool that can be used, that it actually restores a normal rhythm or a perfusing rhythm for our patients. So a very important device. It's an automated external defibrillator with electrodes. I do have a video for you to look at, so just look in my notes section and take a look at that when you get a chance. This device is very simple to use. Lay persons, healthcare personnel are able to use this device. Obviously, healthcare personnel, but even lay persons can use this device as well because it's so simple. It actually gives instructions on what to do, step-by-step instructions. I don't know what the instructions, what grade level they're written to, but the way it sounds, it could be as low as the 8th grade. So very user-friendly device. They can be found in many places, malls, airports, and commercial jets or gyms as well. They have them at my gym as well. Whenever you have a patient in cardiac arrest, you always want to place them on a firm, dry surface. Dry because you don't want them to be all wet, and then you're applying this electricity to their chest wall, because sometimes the electricity would not be as effective in that case. And you want them to be on a firm surface because, of course, when you're doing CPR, the surface has to be firm. You all know that. There are two large adhesive patches that we apply anteriorly and laterally. And I believe they give you a picture that shows you how to do that. Now, sometimes someone may have an excessive amount of body hair, and if that's so, and these electrodes, adhesive patches do not stick very well, it gives you a couple of them in the pack, and you can apply them and apply it, and then pull it off, and it'll remove the hair, and then you can replace, or you can place the other patches onto the torso and get better contact. One thing I always think about with patients, and I think healthcare providers should educate our patients about, and I even thought about doing a study on something like this, but I think we should instruct our patients to shave, if they have an extensive cardiac condition, they should shave their body hair, especially in the torso area. I know that may sound crazy, but you'd be surprised of the delay and the problems that you have when these patients have an excessive amount of hair. And, if they're that close to possibly dying, then why not shave all that hair so that you can possibly, in the event that you have to use this device, you don't have all the delay, if you will. But anyway, now, just like a cardiac defibrillator in the hospital, even outside the hospital, whenever the rescuer, or rather the rescuer should stop doing CPR when this device is analyzing the rhythm. Because if you're pressing on the patient's chest wall while the system is monitoring or trying to analyze the rhythm, then your compressions are going to show up on the monitor, and it'll show up as some wild, bizarre-looking rhythm. So you want to stop compressions. Everybody should stay away from the patient. And when the system informs the rescuer to deliver the shock, then no one should be touching the patient. All right. And then the shock is delivered, and then you commence CPR, high quality CPR. Anyone have any questions? All right, so these are some of the concepts, interrelated concepts. So the priority concept is perfusion. So remember I told you, it doesn't matter for the most part what the cardiac condition is, perfusion is going to be, in most cases, your priority concept, because if the heart is not pumping adequately for whatever reason, if blood flow is impeded for whatever reason, then there's going to be a perfusion issue. And the symptoms are universal. Poor cardiac output leads to what? Dizziness, chest pain, weakness, basically those symptoms that result from a lack of blood flow is what you'll see. And there are some, there are these universal, or classic, I should say, classic signs and symptoms. I think I went over that with you all. Just want to do something. Yeah, so it's fatigue, confusion, agitation, decreased level of consciousness. Now remember these symptoms now, because it doesn't matter what caused the perfusion issue. These are the symptoms that you will see when the patient has a poor cardiac output. You have cool peripheries. So in the peripheries, your arms and legs and so forth, they'll be cool, mottled peripheries and delayed in capillary refill time. There's hypotension, you're not perfusing, tachycardia or bradycardia. There's a thready pulse. There's a raised jugular venous pressure or JVD because blood is backing up even into the right side of the heart, and breathlessness and hypoxia because you're not perfusing. So if you guys can remember those signs and symptoms, it doesn't matter if it's too fast of a heart rate or too slow of a heart rate, you're going to have these classic symptoms. All right, remember that. Very important. And of course, the interrelated concepts for this chapter is fluid and electrolyte balance, because as we said, you need fluid and electrolytes to in order for the heart to work properly, right? And also clotting. If perfusion is slowed significantly, or so if it's slow for whatever reason, let's say atrial fibrillation, and so blood is not flowing at a rate that it normally, if you will, then blood becomes stagnated, and then patients can develop a clot, especially in their atria, because the atria during atrial fibrillation is basically fibrillating. It's just quivering, right? You're not getting that strong lubbed up, but it's just quivering. And so as a result, clotting can develop, because blood is supposed to be moving freely, unobstructed, right? Now, if you look at this picture of the conduction system, and I'll say this to you before you get there, those who are going to term 6, which is health assessment, you're going to get a test question, more than likely, if it's still there, that tells you to list the cardiac conduction system in order. So remember, the SA node is the pacemaker. It always starts, well, when it's normal, it always starts off the electrical impulse. So it starts from the SA node to the AV node. The impulse moves down to the AV node, then to the bundle of His, then to the right and left bundle branches, and then to the Purkinje fibers. And when the Purkinje fibers are stimulated, then this, if you can see my cursor, the ventricles squeeze, and this is when we get blood that is pushed out to the aorta and then into the systemic circulation. And on this side, blood is pushed through the pulmonary artery and into the lungs, where oxygen exchange takes place. So you must remember the order, all right? If the SA node loses its ability to be the pacemaker, then the AV node would take over. And then if that happens, well, if the AV node loses its ability to now take over as the pacemaker, then the lower conduction system will kick in. And so the heart rate will continue to decrease as it goes, as the lower system becomes the pacemaker. So with the SA node, the normal heart rate is between 60 and 100. If something happens where the SA node is destroyed, let's say as far like an MI or something like that, then the AV node would take over, and the heart rate is between 40 and 60. And then if something happens to the AV node, it moves down, and then the heart rate will then be 20 to 40. 20 to 40 is not enough to sustain a patient. Go ahead and go to break and come back at 9:10, and we will continue this discussion.
Real quick, I have a question.
Yes.
Does this conduction system correlate with obviously the blood flow and everything?
Yeah, because if that electrical system is off, so will your perfusion system. Because remember, the rhythm, the electrical rhythm is what stimulates the heart, the strength, well, not the strength, but the ability of your heart to pump. And
Right.
let's say if that electrical system is disorganized, how do you think your heart muscle is going to beat?
It's not going to.
Yes. It's going to be abnormal.
Right.
So if it's all disorganized and maybe let's say kind of quivering as in atrial fibrillation or quivering as in ventricular fibrillation, you're not getting much of a cardiac output.
Exactly. Okay.
Yeah.
All right. Thank you.
Yeah. Good question. Yes, ma'am. I'll be back in 9:10.
Okay. Thank you.
Thank you. All right, folks, I am back. It's 9:11.
Hey, Dr. Cooper,
Yes.
this is Chanel Martin. I don't know if it's showing up my name at the bottom. I see the CM, but I don't see my name. I had to switch over from my daughter's Teams account, so
Yeah, I see it.
okay. I just want to make sure it wasn't showing her name like it did previously before.
Oh, I didn't even notice.
Okay.
No, so you're good. You're good. Thank you. You guys have any questions at all so far? All right. Stop me at any time if you have any questions. Don't hesitate, please. All right, so back to the cardiac conduction system. One of the things I wanted to show you, all right, so whenever you see this electrical rhythm, which is a normal electrical rhythm, you got the P wave, the QRS complex. These are complexes. So the P wave, the QRS complex, and the T wave, right? And this is what it would look like on an EKG rhythm strip. So what this P represents, when you see a P on an EKG rhythm strip, and you see how this dotted line points to this this section of the heart, which is the atria, both atria, by the way, right? So when the SA node fires, all right, and the atria contract to push its blood through the tricuspid valve over here and the mitral valve over here, this is what you will see on the EKG rhythm strip, this P wave.
So that's for atrias?
Now say again?
Was that for both atrias?
Yes, it is. It
Okay.
is. They just have it on this side just to, because this is written on this side, but it is both sides because they squeeze almost simultaneously.
Okay.
Now, when you see the QRS complex, same thing. You see this structure here, and it's pointing. It encompasses both ventricles, right? And so when you see this complex, it means, and it's called depolarization. Whenever the atria squeezes, it's called depolarization as far as the electrical system is concerned. When that impulse fires off. Anyway, so yeah, so when that impulse fires off in the SA node, it's called depolarization, and you'll see that P wave. And then when that impulse continues downward into the lower chambers, you'll see the QRS, again, depolarization. And then when you see the T wave, the ventricles are just going back to a kind of a resting state, if you will. It gets a little more complicated than that, but suffice it to say, it's going back to a resting state, repolarization, going back to a resting state. R for resting. All right, and so again, so you'll see a P, and I'll show you in an entire rhythm strip. So you have a P, QRS, and a T, and that's what it's showing. All right. And these, and you'll see some other as we progress through the slides. You'll see these slides where it has all kinds of different letters that describes what different portions of the electrical system, but we don't have to worry so much about them. Although the QT interval, we will talk about that. So there's a QT interval. When you look at an EKG rhythm strip, well, not a rhythm strip, but an EKG, it will tell you, I believe at the top, how long the QT interval is. All right. And I think the high end of it is 430. So between roughly 400, 430, roughly, If it's any longer than that, then it can place these patients at risk of this abnormal rhythm we call a torsades de pontis. And this is when the rhythm is very abnormal, and it looks like V-tac, but it's like it's twisting, all right, twisting on a helix, all right? And that's the importance of knowing the QT interval in seconds. It measures it in, I believe it's milliseconds or seconds. So when we look at these different rhythm strips, from the P wave to the R wave is measured in so many seconds. Same thing with the QRS is measured in so many seconds, and same thing as far as the QT. So if those rhythms are within the normal seconds, so for example, the PR interval, it should be between 0.12 and 0.20. That's normal. If there's anything that is longer than that, all right, then that's abnormal, and it can indicate some kind of pathology in the electrical conduction system. What is that? It could be a number of things. It could be an electrolyte issue. It could be medications that causes it as well. So always check your medications when you see an abnormal rhythm. All right. Always look at your medications. Never forget that. Look at your medications. And we'll get into the seconds and what their normal numbers are and so forth, and you'll see better what I'm saying. But I'm just trying to give you a prelude for what to expect before we get there. Now, as I mentioned to you, the electrical, this is your electrical system, and the electrical system, the electricity is initiated first, and then the mechanical function or contraction of the cardiac muscle will follow. And this is how a pulse is generated, blood pressure is produced. Basically, the electrical system innervates rather the cardiac muscle. It stimulates the cardiac muscle. You can have electrical without mechanical, but you cannot have mechanical without electrical, all right? Because the electrical stimulates the muscle. The same thing with your nervous system. When that nerve impulse is sent from the brain, and it meets up, the nerve and the muscle, the neuromuscular junction. It takes the electrical system and the nervous system to stimulate the muscles, let's say in our hand, and causes us to be able to move. All right, so it does take an electrical impulse to do that, but it's in the nervous system. Same thing with the heart. And of course, the heart is a very special kind of tissue. The cells of the heart are very different, very unique. And when I say unique, the heart can't contract on its own without influence from anything else in the body. So the electrical system has these what we call specialized myocardial meaning the muscle of the heart, or the muscles of the heart, of the cells itself. Now, these cells are so special, they regulate the heart rate, the rhythm, and they do have these unique properties that other cells do not have. All right, for example, they have what we call automaticity, excitability, and we'll go over these terms here shortly, conductivity and contractility. All right, and we know it has contractility because when the DNA of the cardiac cells instruct the cardiac muscles to contract, then they do what? They contract. And this is why when we do not get an adequate blood flow to the heart, right, those cells are starved. They're deprived of oxygen and nutrients and vital minerals. And therefore, the DNA of those cardiac cells cannot carry out those functions. And it loses its function to the automaticity, excitability, the conductivity, and the contractility. It loses those properties. And this is why oxygen, nutrients, and vital minerals are so important. Questions?
No, sir.
All right, hopefully it's making sense to you guys. Let's see, I won't even read that. And also, just make sure you take a look at my notes as well. Lots of good information. It should elucidate much of the information that we're going over. So now, in looking at this slide, the cardiac conduction system continues. And as you can see, this is the SA node. Look at the heart rate, and that's signified by the P wave on the EKG. Then you have the AV or atrioventricular junction. Look at the heart rate here. When it talks about the contraction known as atrial kick. So when the atria are working normally, then it's squeezing an adequate amount of blood. Let me go back. When the atria are squeezing, right? When both atria are squeezing, it squeezes a certain amount of blood into the ventricles, right? When someone is in atrial fibrillation, remember the atria are fibrillating, they're quivering. You don't get the strong squeeze, lubbed up, right? And so when they're fibrillating like that, then you don't get that full cardiac or an adequate amount of blood. You don't get an adequate amount pushed into the ventricles because it's quivering. And what that means is you're losing a certain amount. Now, hear me good, because this is very important. You're losing a certain amount of cardiac output when that happens, because if there's a reduced amount of blood that is coming into your ventricles, then it will also be a decreased amount that is being pushed out into the arterial system or systemic circulation. And we call that the atrial kick. So we say with patients who have atrial fibrillation or atrial flutter that they're losing their atrial kick. They're losing about 25 to 30% of their cardiac output. So going forward again, so when you read where it says contraction known as the atrial kick, this is what's happening with that abnormal rhythm, which we haven't gotten to yet, by the way. All right. So then if something happens to, let me go back again, if something happens to the SA node, if something happens to the AV node, then the bundle of his takes over as pacemaker. And check out what that heart rate is then, 20 to 40. You cannot have a good cardiac output with a heart rate that's slow. All right. And then the impulse moves down to the Purkinje fibers. All right. Any questions?
No.
All right. Now, remember I told you about the specialized myocardial cells. And so these are those concepts I just mentioned, the automaticity, excitability, conductivity, and contractility. The heart cells, the heart muscle cells can carry out these functions despite of what's going on throughout, well, let me say, it can carry out these functions and it doesn't rely on other organs or systems to necessarily bring this about. So you have this automaticity, meaning the ability of cardiac cells to generate an electrical impulse spontaneously and repetitively. Doesn't depend on any other cells to do that. It can do it on its own. It can create an electrical activity. Excitability, ability of non-pacemaker heart cells to respond to an electrical impulse that begins in the pacemaker cells. So all the cells can respond. Once the pacemaker sets off that impulse, then all the other cells can respond. Excitability, they respond to those impulses, right? As far as the electrical or conductivity, ability to send an electrical stimulus from cell membrane to cell membrane. Guys, let me say this to you. And this is nobody on this call when I say this, but I had to deal with an issue about, I'm assuming these EAQs again. I took the time and I sent an email to someone explaining why there's a delay in updating the grades. Now, this particular person, the problem is I either didn't see the name in the system or the system appeared to show they didn't complete the EAQs. But I did say I would take care of it. And of course, I'm getting these calls. And the reason I stopped to say that is people focus on what is most important. I'm not going to do you wrong. All right. I know how to do my job. I may not do it as quick as you think I should do it, but I will get the job done. Believe that, right? Believe that. I will get the job done. I find it ironic that, and I know you guys can identify with this, people come to healthcare, and I'm just talking in general, people come to healthcare and they think that we should respond to their needs immediately. But when you go to their job, their workplaces, whatever business you're conducting, be that something dealing with your car or maybe your bank account or whatever the other issue is, they'll give you any old kind of service and they do it in their own time, and you better not rush them. But then when it comes to us, the standard is different. I agree that if your heart stops beating, then yeah, that's an immediate problem. But these are EAQs, people. My God, the world is not ending. Give me some time. Nobody's going to die. It's not an emergency. This is not 911. Oh my God, I mean, give me some time. Stop stressing. You're going to stress on one thing and you're going to do bad on the thing that you really need to be focused on. All right, off the soapbox. Anyway, contractility. And I'm not trying to be insensitive to your concerns, but I told you, what do y'all think, I'm a crook? You think I'm going to say one thing and fake you out and do something different? I told you, this is on recording. All right? If you want to call my hand, tell administration, tell him to play that recording. He gave me an F. I got an F in this assignment, and he said he would do something different, so he contradicted himself. I'm telling you what to do to get me in trouble if that's what your aim is. All right? So stop stressing, man. Focus on what is necessary. All right, now I think I'm off the soapbox. I may come back to it, but for now, let's move on. Uh-oh. All right, so contractility, the ability of the atria and the ventricle muscle cells to basically contract, all right, when they're stimulated by the electrical conduction system. Again, this is what causes your blood pressure and your pulse, and it's the mechanical activity of the heart, basically. People, I'm not trying to cheat you. Believe me, what benefit would it do for me? Your success makes me look good. Understand that. Nobody's trying to take anything away from you. You pay good money. You pay good money to be here. I want you to be as successful as I want to be. Did someone say something?
No, sir. I was just agreeing with your success.
Yeah, hey, I want to see you successful too. What do you think? I want to see you bomb the HESI? I feel bad when you guys bomb the HESI, you know, in general. I feel bad about that. I feel like I didn't do my job, you know? That's why I give you the HESI concepts, you know, so that we can figure out how to study for this thing and be successful. I'm trying. Yeah, and I appreciate you doing well. Makes me look good. Right? I'm not a crook. You know, I'm going to do you right. Promise you that. I treat people the way I want to be treated, by the way. All right. So this is that depolarization, repolarization I was talking about when the impulses travels from the, all right, so when the SA node kicks off, so it's the electrical first from the SA node, and then the atria contract, and then it reaches the ventricles, and then the ventricles contract. That's depolarization. And it goes back to that kind of a resting state, so to speak. Then you're talking about the ventricles kind of going back to a resting state. But don't get caught up on these terms. I just wanted to mention them to you. So if you see them again, then you'll understand. Let's see. All right, so this is how a 12-lead EKG, how the leads would be applied. So just take a look at this. When you guys get in, I say you're in mental health now, so this would be apropos for you all. So with Professor Thody, one of her pet peeves is that you guys know how to place these leads on your patients. So look at how on the right side of this patient is the V1 lead, and it's placed at the, see, 1, 2, 3, 4, about the fourth intercostal space on the right side of the sternum here. And then the rest of the leads, look how they are, look at the pattern of how they're placed, right? So V2 to V4 are placed on this side, right? And then you place your limb leads on both of your wrists, and then your limb leads on, and then of course you didn't get your EKG. Now, one of the things I want to tell you is sometimes we have a 5-lead EKG system, and when you do, as I mentioned to you, sometimes you have these patients with the chest or the torso has a lot of hair on it, so you want to shave those areas when you place those leads on. Sometimes the skin is oily, and when you take those leads and you place them on the patients, they lose their ability to stick. They lose their adhesive ability. These leads also have a kind of a gel in them, and it helps to make good contact, so you get that good electrical activity or rhythms that shows up on the monitor. So sometimes if those leads have been on a patient's body for a very long time or too long, they dry up. And then when you look at the EKG monitor, it looks kind of funky. It looks like there's a lot of artifact, and it just doesn't look right. So we have to change them out as well. We have to also, we sometimes take a 4x4 and we'll kind of rough up the skin a bit, and then we'll place the leads on, and then they'll stick a whole lot better. All right, so just remember those little tidbits up there. And we have to really clean the skin, you know, and make sure it's dry before placing these leads on, because they do stick by way of an adhesive kind of material. All right, and with the 5-lead EKG, they're basically placed in the torso area, not the 12-lead, what you're looking at here, but the 5-lead when they're on continuous monitor. What I want to tell you about that, you never place your leads. Well, let me try back up. So when you place the leads here, the patient is pretty much still. They're lying still, right? Because if this patient starts moving their arms and legs, it would look like artifact. It would almost look like ventricular fibrillation or some other abnormal rhythm. So you have them lay still, like you do an X-ray, lay still, and do the EKG, and then you of course remove them. But patients who have the 5-lead EKG, you don't place leads on the arms and legs. You just place them on the torso, because if you place them on the arms and legs, all that movement, it would look like an erratic complex. You don't want that.
How long would we leave on to get her there?
It's like within seconds. Yeah, they don't have to sit there. They don't have to lie there for too long.
Okay.
Yeah. And these leads that I was telling you about, they're also called limb leads as well, even though they're not on the limbs, but the ones that we place on the ribs. And I think I have a YouTube video if it's still working. Because some of these links they stop working. But take a look at it, or you can Google it. Not Google it, but you can do. If those of you who are not familiar with it, go to YouTube and type in 5-lead EKG. It'll show you how to place them. Usually the white one goes, and some of you probably know this better than me, because I always forget the kind of a mnemonic, if you will. But the white one goes over the right chest wall, and the black one goes over the left, brown in the center, and then I think, what is it, smoke over fire? Because there's a green and a red lead.
There's a red on your lower left and a black on your top left.
Yeah, what is it? A cloud over green and
Smoke over fire.
smoke over fire. It kind of helps you remember where to place them. I always forget that for some reason. I just knew where to place them. But that can kind of help you. White over right, and then of course the black one goes on the left side, and then so forth and so on. What else can I tell you about that? Anybody can add anything else about this if you work in this area? I might be aware. Yeah. Yeah. So anyway, and sometimes those leads are, there's a little box that they have. Sometimes it's hardwired. Well, sometimes it just connects to the box itself. There's a little box that fits into the pocket of the gown, patient's gown. And then sometimes those leads are connected to a monitor. I prefer the little box as opposed to being attached directly to the monitor, because the patient can be more or less mobile. They can walk around the room and around the nursing station, get exercise, and they don't have to be tied to a monitor. But it depends on the organization where you're working, if that makes sense. All right, now we're really getting ready to get into the nitty gritty here. All right. Before getting into this one, I want to show you guys something. It's what we call calipers. So let me share my, let me share my desktop for a minute. They're called ECG calipers. Show you what it looks like. All right. You know. All right. Do you guys see the EKG calipers here? This is what it looks like. This is how we measure our EKG complexes, and it informs us as to whether it is the rhythm is normal or abnormal, and it is measured in seconds. If those seconds are too long, or if the time is too long, too short, but mostly too long, then there's a problem usually. And we have a set criteria that tells us what the normal is, and if it's anything outside of that, then there's a problem. Now, you guys see these two different points right here? This is what we place. We place 1 point at a certain portion of the complex, and this other point on the next section of the complex, and then we can measure it by way of the EKG paper, which I will show you. I just have to demonstrate it with another document. Actually, let's see, while I'm at it, I might as well do this. Let me do this. Let's see. Copy. All right, I'm gonna share this my this Word document that I copied and pasted EKG rhythm strip onto. So remember, just keep in mind the visual of the calipers. Those are EKG calipers. Those things are very dangerous, by the way. Make sure you keep the covering that it goes into, because the pointed portions of the calipers are very painful when they stick you. All right. Now, what we do here is we measure. For example, you see here where it says, make this a little bigger. You see where it has the P wave. So we measure, like, the PR interval is important, because the PR interval tells us about the number of seconds the impulses are traveling in the SA node, which we're looking at the P wave in particular. So the time it takes going from the beginning of the P wave here, just look at my cursor, here to here, that's our PR interval. And the normal range is between 0.12 and 0.20. And then, of course, if we're measuring the impulse going from the QRS from the beginning to the end here, then and we measure it against the paper, then it tells us the number of seconds, which is between the number of seconds, or the normal number of seconds, is 0.04 to 0.08 or 0.10 or something like that. It seems to kind of vary. All right. So here's what we do. So let's say, I'm going to see if I can draw this. All right. So we would measure from here. Sometimes this makes my screen go dark, and I don't know why. Maybe it's because I have it on my extended monitor. So if it goes dark, it'll come back. All right, so you all see where I have those two red lines? So you would take the calipers, right? Remember, the calipers look like this. Something like that, with those two pointed ends. So we take this end and place it, let me do this. So we take one end and put it here, and the other end of the calipers and put it here. So we take this caliper that you see here, place one end here, and then we'll bring it over to the top of these boxes, and we'll put the one end here and the one end here, wherever it falls, because these boxes represents a certain number of seconds. And so this depiction here, this grid here, is just a larger representation of this grid here, of each of these square grids with even smaller squares. All right. It just blows it up so you can see what it looks like. So each of these boxes represents 0.04. So 4, 8, 12, 16, 20. So if I was to measure this EKG or this PR interval from here to here, all right, because we're looking at the time it takes for the atria to squeeze, right? Looking at the electrical impulse. So if I was to take those calipers and measure from here to here, what would be the measurement of that of the PR interval?
0.08.
Say that. I'm sorry. Say it again.
0.08.
0.08. Exactly. So if I was to erase that, and let's say if it was from here to here.
That's 0.16.
0.16?
Yes.
Exactly. So if it's 0.16, is that normal?
That's for which segment is that? That's
This is
for the PR.
The P
This-
segment?
Yeah, this is the PR interval. Remember the normal range is between
0.12.
0.12 and 0.20.
That's normal.
So that would be normal.
Yeah.
So what if this measurement was this?
There's a delay.
Is that a delay there?
Yes. Oh wait, no, for that whole thing?
Right.
No, that's considered normal for 0.20 sec, 0.2
Exactly.
second.
Exactly. Well, we haven't gotten to it yet, but we will, and I'll show you guys. But the criteria is for the PR interval, 0.12 to 0.20. So yes, that would be normal. However, if I did this,
Okay.
what would that be?
That would be a delay. Too long.
That would be too long. Right. So, and we do the same thing with the QRS. And so what we do is we say, so we take these calipers and we place one end here and one end here. And then we bring the calipers up here. And let's say if it measures hypothetically from here to here, what would that be? Right here. What would that be? What would the measurement of this be for your, I'm sorry, scratch that. I didn't mean to make it that big. What would it be if, uh-oh. If it was between here and here, what would that be?
That would be 0.08.
And then that would be considered normal. Now check this out. What if, let's say if we're dealing with the PR interval again, and it was this.
0.10.
Yes. 4, 8, it's not the whole thing 12, so it's half of it. So you just get 0.2 out of that. So yes, 0.10. Is that normal, 0.10?
No.
It's not normal because it has to be 0.12 to 0.20. You guys, you're going to learn, now this is where memorization comes into play. Remember, I always encourage you or discourage too much memorization. Get more understanding rather than memorization. In this case, this is a memorization piece. All right, this is a memorization piece. So do you guys get how we're using the calipers?
Yes, sir.
All right, not difficult, not difficult. This is really easy, to tell you the truth. And we're only measuring the PR interval, the QRS interval. That's what we're usually measuring. And you'll see that as we look at the criteria. All right. I kind of like that I have the ability to draw this, and you can see it a whole lot better. Let's see. Let me make this. I'll share that again. All right. Now, remember, I always tell you guys to know the abnormal first, excuse me, know the normal first, like normal anatomy and physiology. And then anything that deviates from that, you may not know necessarily what it is at the time. You may not know what the pathology is at the time, but something is abnormal. And even doctors don't know at times what the actual cause or the actual problem is. You just see some symptom or something going on, and so you start investigating. You're ruling out this and you're ruling in that by using different tools, labs and other diagnostic tools, right? But we know this because for example, the normal breathing rate is between 12 and 20. So if you see a patient breathing 7 breaths per minute or 28 breaths per minute, you know something is wrong. You don't know what's wrong, but you know something is wrong. All right. You know, if that patient keep breathing at 28 breaths per minute, they may give out, tire out, and stop breathing. You know, if they're breathing only 8 breaths per minute, they're going to begin to build up a lot of CO2 and go into respiratory acidosis before going into metabolic acidosis, right? So you know that's the abnormality and the consequences if we don't do anything about it. So that said, this is your normal sinus rhythm, right? That's your normal sinus rhythm. Because there should always be a P, QRS, T. P, QRS, T. P, QRS, T. P, QRS, T. And all the way down the line on that strip. And look how regular they are. And we'll see the criteria here shortly. Look how regular they are. If I was to take a caliper and open it up to one point here and one point here, and then I was to move it to here, not spread them apart, but just move it from here to here, and then from here to here, from here to here, and not have to keep on moving it and adjusting it too much, then it would be considered regular. Even if I have to move it less than 3 tiny boxes, it would still be considered regular. All right. So this is what a normal EKG would look like. Now let me say this. So that's what a normal EKG would look like. And I'll come back to this. That's what an abnormal EKG would look like. That's ventricular tachycardia. That's ventricular fibrillation. These are abnormal. All right. These are abnormal. And this is a ventricular asystole. Now, these particular rhythms, you definitely don't want because you're getting a decreased cardiac output. With this one, you're not getting any cardiac output. This one, you're getting very, very, very little, if any. This one, you might be getting some, but not as much. Your cardiac output is compromised because look how fast that heart rate is. That's abnormal. That's the big deal with a too fast or too slow heart rate. You may lose the cardiac output. And then those symptoms I told you about. This one, let's see, no. This one at the bottom is a sinus bradycardia. This is a sinus bradycardia. It's slow. So this can also result in poor cardiac output, or sometimes the patient can still maintain a good blood pressure. It all depends. Now, let me say this to you. Whenever we talk about a normal sinus, we're talking about all those rhythms that come from upstairs. This is considered upstairs. The atria are upstairs. The ventricles are downstairs. The reason I characterize them like that, the reason I describe them like that is because sometimes we say we're giving these patients, if they have an abnormal upstairs problem, a cardiac problem, we call it upstairs drugs. Or if they have an abnormal lower ventricular problem, we call it downstairs drugs. Upstairs drugs, because it's above the ventricle, and downstairs drugs, which are the ventricles. So anytime there's a sinus problem, see right now we're just talking about we'll be getting into more of sinus problems. And then we'll hopefully get into the ventricular problems. When I say ventricular problems, remember this, what I showed you here. This starts, when we get to this slide here, it starts those rhythms that originate in the ventricles. The other problems originate in the atria. These particular problems, when you get to it, originate in the ventricles. Question, which problems are worst, upstairs or downstairs?
Downstairs,
Why?
because that's what pushes blood out. Ready?
Exactly. That's what pushes blood out into the systemic circulation. If you got a problem with the ventricles, you got a problem. You got a problem. It even says here, left ventricle pumps oxygenated blood through the body to perfuse vital organs and tissues. So you got a problem. And so these are all ventricular rhythms or dysrhythmias. They all originate in the or downstairs in the ventricles, right? Whereas though these problems like sinus tachycardia, sinus bradycardia, sinus, all originate in the atria. Does that make sense?
Yes.
So when you're doing your readings, you'll understand the significance of, these problems in the ventricles, atria and ventricles. If you have atrial fibrillation, atrial flutters, things like those types of problems, sinus tachycardia, sinus bradycardia, all those are upstairs problems, atrial problems. All right. Oh, what I meant to show you here, if we're trying to figure out the rate, this is a 6-second strip. Why do we know it's 6 seconds? Why do we know it's 6 seconds? Can anybody show me why?
It says 3 seconds.
Yeah, it says 3 seconds here and 3 seconds here. You combine those, you have 6 seconds. It's a 6-second strip. Now, what we do is we count all the QRS complexes that are within this 6-second strip. So to be from here to here. You won't count this one because this one lies outside of the 6-second strip. But everything else is within the 6-second strip. So how many QRS complexes do we have in the 6-second strip?
9.
All right, and for that reason, we take 9 times 10, always by 10 in this case, and it gives you 90 beats per minute. And that's how you get your rate. All right. Go ahead and come back at 10:10 and we'll continue. Trying to keep you on target. Oh boy. Oh boy. All right, everyone, we are back. We are back. We are back. Is everyone online? I don't know if I'm having some connectivity issues.
I'm here.
Yes, sir. This is Chanel.
All right. All right. Just don't want to be talking to myself.
I'm here too.
I do that sometimes, but, I see you, Ms. Els. I do that sometimes, but kind of embarrassing when people walk in the room and you're talking to yourself. It's good stuff, but, you know, I call it counseling with myself. So nobody else will hear me. I hear myself. Anyway, so now you all have been exposed or been educated on how to get your rate. Because I mean, you know, when you're looking at an EKG, there's like a criteria that we look at, wherein we determine if it's normal or abnormal, and we'll get to that as well. Very easy, very simple. Well, before we even get to it, there always has to be a P. It has to be the same configuration or morphology or shape. When we say shape or morphology or configuration, we're talking about basically the shape. There always should be a P that precedes a QRS, right? The seconds have to be within a certain number or range for the PR interval as well as the QRS. They should be regular. See, from here to here to here to here to here, they should all be regular, right? And the short of it is, this is what informs us whether or not it is normal or abnormal. All right, and we'll get to that, and you'll see what I'm saying. Very simple, very simple. All right, so remember when I told you that you have all these different letters that tells us, you know, tells us something about that rhythm, right? And so what we're mostly concerned about is the P wave, the PR interval, the QRS, I don't have it in red, but yeah, the T wave is important, and the actually I think it should be the QRS duration as well, and the QT interval. I need to go back and you know, change the font color, but a QT interval, as I mentioned to you earlier, right? All that's important. So. All right. So we know you know, there's a certain seconds that we'll be looking at when we're talking about the PR interval, the QRS duration, and the QT interval. And we want to also know if a P wave is present, if a QRS is present, and if a T wave is present. All right. So those are important. All right. Again, the PR interval is from 0.12 to 0.20 or 5 small blocks. that would be considered normal. The QRS duration, now I have 0.04 to 0.12. Sometimes you'll see 0.04 to 0.10. So it just, depends on, I guess, what source you're looking at. And of course, you have the QT interval. And I believe that the normal range is, I know it's no more than 430 roughly. If it's longer than that, then you can have what we call torsades de pontis. Matter of fact, let me kind of show you that. Can you all see this rhythm that I'm showing, torsades de pontis?
Yes.
Yes, sir.
You see how it appears to be going one direction, and then it twists, and then it twists again, and then it twists again. All right. This is what we call torsades de pontis, and the rhythm seems to be twisting, or these rhythms seem to be twisting on a helix. They're just twisting. See, it starts off as a ventricular, as a V-tach, and then it starts twisting like this. And this can deteriorate into a ventricular fibrillation. And of course, with a rhythm like this, your cardiac output is just kaput. You don't have a good cardiac output. All right, it's too fast, and your ventricles are not beating very well, not getting good squeezes. So that's torsades de pontis. And that's why when we talk about the QT interval, there's certain medications that people are placed on that can actually cause the QT interval to be elongated. And if that's the case, and if it's not corrected, it can end up with this type of rhythm, which can progress into a ventricular fibrillation. No good. No good. All right, so I'm sharing again my PowerPoint. All right, so that's what I want to say about that. And we'll talk about, there's a condition called QT syndrome, and it does affect certain ones are at risk, or there's certain causes. It could be a gender, be medications, could be just different things, and we'll kind of hit those points. All right, and when you get a chance, you can just take a look at some of these, these different complexes that are designated by a P or PR interval or QRS complex, and QT interval. See the QT interval here. Right here, it tells you that the P wave tells you that, or represents an atrial depolarization. That's your P wave. It means that electrical impulse from the SA node will bring about or stimulate the atria, and you'll see this characteristic P wave. And then you look at your QRS complex. It represents ventricular depolarization, and it's measured from Q or R wave ending at the S wave. All right, and it gives you a certain number, and so on. Right now. Each of these tells us something about the conduction system or the health of the conduction or electrical system of the heart. For example, and this is very, very important, a long PR interval can be due to certain medications. For example, patients taking calcium channel blockers, beta adrenergic blockers, digoxin, and so forth. And so when you see a prolonged PR interval, so right here, when you measure from here to here, which is your PR interval, and it's more than 0.20, it can be due to those medications. And so what you need to do as a clinician is, all right, so you're looking on you get your EKG strip, you measure it, and you see that it's point 24. The first thing you should do is, well, first thing you should do is to make sure the patient has a good perfusion. But when you get a chance, look at those medications. If you don't know them right offhand that your patient is on, because you may have 5, 6, 7, who knows, patients. You can't remember everything. But look at that medication list, and you might see that they're on these different drugs, which might be contributing to this long PR interval, which is supposed to be, again, between point 12 and point 20. Now, when we talk about that prolonged QT interval from Q to T, right? It's something that is called a long QT interval, or long QT syndrome, or prolonged QT interval. It can be inherited, or caused by medications or other conditions. It can be due to someone's age, females that are at high risk for this condition. Those patients who have left ventricular hypertrophy, remember that's when the left ventricle becomes thickened because of all that pressure, the afterload it must overcome, so it gets bigger. It can be due to heart failure, which we know left ventricular hypertrophy, or LVH, can be due to heart failure. It can be due to myocardial ischemia, hypertension, diabetes, also an increased thyroid hormone concentrations, as in hyperthyroidism. It can be due to elevated serum cholesterol, also a high body mass index, as well as a slow heart rate or electrolyte issues. So it's a number of things that can cause a prolonged QT interval, and I showed you what it can lead to. It can deteriorate into ventricular fibrillation, and that's why you want to correct it if it's too long. So if you guys type in normal QT interval, the normal range, actually I was a little off. The normal range is below 400 to 440. But you might get some different numbers somewhere else. But it appears to be between also 350 and 440. So it just depends on the source. But if it's greater than 440, then that is considered 440 milliseconds, which you'll see on an EKG rhythm strip. Then you know that it could possibly deteriorate into a more lethal rhythm if it's not corrected. This is why when you place some of these patients on some of these downstairs anti-dysrhythmic medications, you have to keep them at like Tickerson. You keep them in the hospital for a few days, and you do a serial EKGs from day 1, 2, and 3, while you monitor them on this new medication, right? And because you want to see if the QT interval prolongs. If it prolongs too much, you want to adjust the medications. Let's see something. I don't want to give me that. I don't want that. I was hoping to what would that All right, can you guys see this EKG report?
Yes.
All right, so if you look at this EKG report and you look over here where it says QTC or QT, that tells you how long it is, and it looks like 400 and something. But you have actually the QTC and you have the QT interval. So I was trying
So
to.
it's actually like measured with the caliper, right?
I'm sorry, say again?
Would this actually be measured with the caliper, or is this on, like, is there a different way to determine this on the ECG strip?
Well, with this one, you'll have to get it by an EKG report. You can't do it with the calibers for this one.
Yeah, I figured.
Yeah, I was looking for something. I can't seem to find it. Well, maybe I won't be able to find it. But anyway, this is where you'll get it from. You get that information from. So just know that, right? And so we know what it can result or what it can deteriorate into. To see. Well, I can't find that. QT. All right, I won't worry about that part. All right, anyway, I won't worry about that. All right, so remember I told you guys that there's there's an analysis or even a criteria, if you will, that wherein we can determine whether a rhythm is normal or abnormal. So what we do is we look at the heart rate. What is our normal heart rate?
60 to 100.
All right, 60 to 100. All right, now, then we determine the heart rhythm. Do we want a rhythm to be regular or irregular?
Regular.
All right, so we look at that. Then we analyze the P waves. Is there a P wave present? All right, so we look at that. And what shape is it? So before I get to that part, let me go back real quickly. I want to show you something. Oh, wait a minute. All right. You see the morphology or the shape or the configuration of these P waves? You see how they look the same? See, they look the same.
Yes.
Right? Not only are they present, but they look the same. Now, what I want to show you is the reason they look the same is because they are coming from the same the same cardiac tissue. You know, constantly coming from that same spot. But say if you saw these P waves that look different, some are rounded, some are flat, some are inverted, and so forth. What that means is the impulse is coming from all over the place. Not only from here, but all over the place. Because all this tissue can, remember the special characteristics of cardiac tissue, it can create or it can originate from these different areas of the atria, right? So when you see different configurations or morphologies or shapes, this is why that happens. Ideally, we wanted to originate from the SA node in one spot, but if they're different, then that's what's happening. So we do talk about the normal looking P waves. All right. Then we look at the PR interval. We want it to be between the range of. That's a question for you.
20 to 12.
12 to 20.
0.12 to 20. All right. Then we look at we measure the QRS duration. And we want that to be between what?
0.4 and
Yeah, it kind of varies, but yeah. And then what is the last step? We interpret. And if anything falls outside of this criteria, then we know that there is a problem.
Would that be the interval?
Well, I mean, that's one criteria. So if we measure the criteria, or do we measure the PR interval, or even the QRS duration, if it's longer than what it should be, there's a problem. And what is the problem? Who knows? It could be an electrolyte problem. It can be, you know,
But that correlates with the ventricles, right?
let's say again.
That correlates with the ventricle problems.
Well, this one does. The QRS duration does.
Okay.
Because remember the QRS, when you saw that that image, they have the brackets around the which included the ventricles, and of course the top bracket it included the atria. So yeah, so the QRS correlates with the what the ventricles are doing.
Okay.
Right. All right. So that's how we do it. Nothing difficult. Nothing complicated. You know, you just have, and you know what? Actually, you don't have to have calipers to do it. Let me show you. Let's see. I want to show you a little trick. So say if I get, all right, let's say if this was a piece of paper, right? This is a piece of paper. My screen kind of goes off, so I can't see what I'm doing. So, but let's say this is a piece of paper. You see the edge of this paper? If I was to measure this, let's say my PR interval, and I place the edge of this paper here, well, let's say if I place the edge of the paper here, well, provided I was looking at the PR interval. So say if I was looking at the PR interval here. So if I place the edge of one point here, and so that's automatically kind of a mark because it's the edge of the paper. And then I place the other one, or I place the paper as I spread it across here, and I make a dash. So in other words, so I bring this paper down here. And so this is one end of it. Or I guess I should do it like this. So this is one end of it. I don't know if it likes that red. And then the other one comes down about right here, right, on this piece of paper. Then I can take this piece of paper and I can move it over this structure here. So let's say if the paper comes, the edge of the paper is here, and it stops here, right here to here. So that'll tell me that my PR interval is between, is actually 0.16. Does that make sense?
Yes.
If you don't have calipers, sometimes we lose our stethoscopes, calipers, or whatever, so we just have to use a piece of paper. So, and if we were looking at our intervals, let's say if between this QRS interval, let's see. So if we put that paper, we put the edge of it here. If we put the edge of the paper here, actually, it keeps doing that. And here, it's doing it with that one too. So we do it from here to here. Let's say we got this piece of paper, and this is where we measured the first QRS, and then we moved this piece of paper from here to here, and it didn't change where we did our markings. And we did that throughout that entire 6-second strip. it would show us that the rhythm is regular, if that makes sense. So we can always, in other words, we can always improvise. All right. As nurses, we're never stuck. We always find a way. All right. So that's what I'm going to show there. I got us marked for the next break, so don't worry. Let's see, what else can I show you on this one? So you can just take a look at my notes that I have here. Well, this is worth mentioning. So the P wave should look like, all right, so P waves are present. The P wave occurs regularly, you know, they're not irregular, you know, you have to keep adjusting the calipers or whatnot. There's a P wave before each QRS complex. The P waves are smooth, they're rounded, they're upright in appearance, or they can be inverted. Even inverted, they can still be considered normal. The P wave all looks familiar. All right, so that tells us, you know, what we're looking for as far as normal configuration. Let's see, so we talked about how to measure. I don't have to keep going over that. And we also talked about how to measure the the QRS duration. Let's see. All right, so I think I covered that enough. Can someone tell me what would the rate be here?
Would it be 80?
Yeah, it is 80, but I got this example from the PowerPoints, and it actually says 83, but that's not a big deal. It can be off by a few, but yeah, I would say 80. Because remember, this is the 6-second strip, those bolden lines. You don't count this one, but you count 1, 2, 3, 4, 5, 6, 7, 8. And that's normal. Remember, look at those P waves. They all look the same. You got a P wave preceding each QRS complex and a T wave. T wave looks a little elevated. All right. But if you do your measurements, all right, so this is normal sinus rhythm. This is what a rhythm should look like. Both the atrial and ventricular rhythms are essentially regular. If you were to take calipers and go from here to here, here to here, here to here, they'll be regular. If you do it with the P waves, it would be the same thing. They're regular. Could be a slight variation. The atrial ventricular rates are both 83 beats per minute. There's a P wave before each QRS complex. All P waves are of a consistent morphology or shape. It means the same. The PR interval measures 0.18 seconds and is constant. Doesn't keep changing, it's constant. And the QRS complex measures 0.06 seconds and they are constant. All right, so that lets us know that this is normal. Now, there is a systematic approach to when we're trying to interpret these rhythms, which we just pretty much went over. But if we were looking at the criteria for a normal sinus rhythm, this is what it would look like. Look at the rate, 60 to 100. That means the SA node is really firing well. And it comes from the sinus area, meaning upstairs in the atria, as sinus. The rhythm is regular. All right. As far as P waves, are they present? Are they of a consistent configuration? Is there one P wave that precedes or before each QRS complex? In the previous one, yes to all these. The PR interval. Is it between 0.12 and 0.20 seconds, and are they constant? It was 0.18 and it's constant, so yeah. QRS duration, 0.04 to 0.10 seconds and constant. Is that the case? Or is that the case of what we were looking at? Yes. This is a normal sinus rhythm. Any questions?
No.
All right. I hope you guys are finding this very simple, or to be very simple. Now, if you look at these two rhythms here, it is referred to as sinus rhythm. Why is it referred to as sinus rhythm? Can anybody tell me?
P wave.
Because it's originating where?
In the atrium.
In the atria. It's originating upstairs. These rhythms are starting from the top. All right. So with this is sinus tachycardia. The heart rate is 110. The PR interval is 0.12, and the QRS is 0.08. So the only thing that's off is the heart rate. This can be considered normal, let's say, as far as a physiological response, if someone is exercising. But if it's just like this, when you're sitting still, no activity, and it's still like this, something is wrong. What's wrong? Who knows? All right. But that's the only thing that's off with sinus tachycardia. That's that the heart rate is more than 100 beats per minute. Now, the flip side of that is a sinus bradycardia. Again, originating in the upstairs in the atria. All right, and this can be considered normal in an athlete rather. All right, but the heart rate here is 52 beats per minute, so it's lower than 60. The PR interval is 0.18 and the QRS complex is 0.08, which is the only thing that is abnormal here is the heart rate. All right, easy peasy. Now, sometimes when the heart rate here gets too low, you can lose your cardiac output and your blood pressure. And then patients begin to experience those classic symptoms that we talked about. Why those classic symptoms? Can anyone say? Can anyone tell me? Remember, those symptoms are due to poor cardiac output. If it's too fast, if it's too slow, you're not likely to have a poor cardiac output with a heart rate of a 110, which is sinus tachycardia, or sinus bradycardia 52. Those are not too low, but yet it sort of depends. But for the most part, you're not likely to see a patient experience low cardiac output as a result. When it starts dropping lower or increasing higher, then you're getting into some dicey territory. All right. Now, this is what we call a sinus arrhythmia. This rhythm also originates in the sinus or upstairs because it's sinus. And to be quite honest, the only abnormality, this rhythm is not really abnormal, but the only thing that, it's not pathological, let me put it that way. It's not necessarily within the normal range, but it's not really pathological. It's due to intrathoracic pressure during breathing. So when you exhale and inhale, it just changes the rhythm of the heart. And so you'll see a QRS come earlier, and then it'll prolong again, and then come in earlier. So it'll be irregular. It's just a rhythm that is off a bit. I'm in the wrong area. Oh, I thought that looked weird. All right, so in physiology, the intrapleural pressure within the pleural space is called intrathoracic pressure. It refers to pressure within the pleural cavity. We have pressure within the pleural cavity. Normally, the pressure within the pleural cavity is slightly less than the outside or atmospheric pressure, which is known as negative pressure. And so when these patients breathe in and breathe out, it just changes, again, the rhythm. These patients are not likely to have any problems whatsoever. So, but just, actually, I should show you, let's see. Not sure if this is a good example. That might be a good example. So if you were to look here, you see how the interval is longer here, and then it comes together with these, and then it spreads out again. That's your sinus rhythm, sinus arrhythmia. Sorry, your sinus arrhythmia. Same thing here. Look at the distance between this rhythm and this rhythm, and then it comes a little closer here. And then it extends again. All right, then it comes together close again. All right, and that's because of that inspiration, expiration, that change in the pressure that causes that to come about, but it's not pathological, as I mentioned. Patients have no issues with these, with these rhythms. Now, here we're talking about some common dysrhythmias, all right? And we refer to them as premature complexes. They can be either bigeminy, trigeminy, or quadgeminy. All right. We'll also be talking about bradydysrhythmias and tachydysrhythmias. Basically, rhythms that are slow and rhythms that are too fast. Again, if they're too fast or too slow, they will result in a compromise in your cardiac output, and then you have those classic symptoms of poor cardiac output. Now, when we talk about bigeminy, and I'll show you an example. Again, these are problems coming from the upstairs. And this is where you have this stimulation of that cardiac tissue, not originating from the same spot, but you have this kind of ectopy, this abnormal rhythms that you'll see because the tissue within your atria are being stimulated. And so it causes some of these beats to or you'll see premature complexes. You know how you see the QRS, and then the next QRS should be regular, but there's a beat that comes very soon, and it looks bizarre. All right, And so let me give you an example because it's better to give you a visual. All right. But before I do that, let me show you something. All right. Let me come out of here and then share again. All right. All right. Let's say you know, I should do this. Oh, well, you know what? Let me do it this way. So let's say if you have a P QRS, it's gonna T. Then you have a P QRS, and this looks a little crazy, but don't worry about that. T, a P, and a QRS, and a T. All right. All right, I guess I can't do that. Anyway, so let me kind of do, I want to do a few more. So a P, QRS, T, P, QRS, T. Uh-oh. Say this is a T. And a P, QRS, T. All right, now, if we're talking about bigeminy, so you see how you have a impulse. You know that this is caused by the impulse when you go from here to here, right? So these are your normal impulses, right? When we're talking about premature, we're just talking about a beat that fires off before it gets to this beat. So what it would look like is some bizarre looking. I guess I should change the color of that. It will be some bizarre looking, all right, some bizarre looking complex that comes before this complex. So you get this bizarre looking complex, all right, that comes, I'm doing it like this. I'll actually show it to you. So, but just bear with me. So it'd be a bizarre complex, right? So that's bigeminy because every other beat is abnormal, right? Bizarre complex. That's every other. Somebody got kicked out. All right. So that's bigeminy. It's a premature complex. There's some irritation of sorts that are going on in the atria. Say, well, why is this important? Because if you have too many of these, your perfusion is going to be compromised because they're not perfusing rhythms. When you see these rhythms, they're causing that squeeze of your ventricles. When you see these abnormal rhythms, you're not getting a squeeze. So they're not perfusing rhythms. These are perfusing rhythms. That's why they can be dangerous if it's too many of them. Right? So that's the bigeminy, every other. Normal, abnormal, normal, abnormal, normal, abnormal. Now, when we say trigeminy, it's normal, normal, abnormal. So every third. So let me come out of this. Give you an example. So with trigeminy, it's every third. Normal, normal, abnormal. Normal, normal, abnormal. Normal, normal, and then you get an abnormal.
So when say, I'm sorry,
Go
when
ahead.
you say that, is it more so the okay, hold on, let me try to, how do I say this? So you got these two normals, and then you got the third one being abnormal. Is it the length between them that's abnormal, or what exactly is abnormal about that? I know that there's a third one.
Well, all right. So you see how I drew these?
Yeah.
See how they get that? Well, bear with me on my artistry. You know, I'm not really autistic, but so these are pretty normal. So you have the normal rhythm. So you get these normal beats.
Mm-hmm.
But I'm purposely making these bizarre looking because they don't look nothing like these.
I gotcha.
All right, and I'll show you an example. So forgive me with you know with the way I'm drawing them now. I'm just trying to make a point that they look bizarre. They look crazy.
Okay.
And I'll show you that. So that's the trigemini. All right, so you already know what the quadgemini looks like. Is what normal, 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 abnormal. So 1, 2, 3, fourth. The fourth one is abnormal and quadgemini. The second one is abnormal in bigemini, and the third one is abnormal in trigemini. I may have repeated myself, but you understand. So
Question.
yes.
Can we go back and replay this video?
You know what? I'm glad you said that because actually I think this is probably the best that I've ever kind of taught this. So I'm going to see if I can upload it so you all can look at it later.
Okay, yeah, because I'm trying to write notes, but I don't want to like stop you. So I would like to go back to write my notes.
Yeah, and also keep in mind that I know it's important for people to write their own notes because they remember it better, and which is fine. But I also have notes as well. So either way, you know, you can refer to. You know,
Okay.
you all do know I have my notes, right?
Yes, in the PowerPoint, yeah, but I want to add my notes to that.
Right. All right, good. That's fine. Yeah, but I'm going to see if I can upload it. There was a time, and either way, I used to have to upload it to a YouTube video, make it a YouTube video, and then share it on in my modules. But now the system has been configured where it gives us more memory space, I believe, and so I can upload it directly. So I'm hoping I'll be able to do the same.
Okay.
All right. Yeah. So yeah, so I'll be able to do that. All right. So check this out. So let's look at a bigemini bigemini picture. Maybe it'll show us, give us an example. I'm usually able to bring one up. Bigemini. What I want to do is show you the bizarreness of the rhythm, right? Uh-oh. I'm not sharing it. Let me share that again. I'm going to send you to break here shortly, but I just want to show you this real quickly. All right. Can you guys see this? The new, I'm sharing something different.
Yes.
Kind of funky, but you see how this normal rhythm here, this normal complex, this QRS complex? And then look at this bizarre looking one here. All right. Look down here. This is a bigemini. Every other. Look how bizarre it looks. Every other is bizarre. It doesn't look like the one that it precedes. And this is just due to some irritation that is going on Sometimes it can be in the atria. Sometimes it can be in the ventricles as well. You all get that? Does it seem simple enough from that
Yeah.
standpoint?
Yes.
All right, and we'll delve more into it when we come back. So go ahead and this time go to 11. We'll come back at 11:15 because I need to do something real quick. All right, everyone, we are back. We have close to, well, a little more than an hour. That's why I wanted to give you a longer break so we can kind of make it through or make it to that time. All right, is everyone else back?
Yes.
Yes.
Yep.
All right, make sure you guys go on camera. We do have people stopping in, and so they need to know that you all are on. Let's see. All right, so remember when we talked about these abnormal, bizarre looking rhythms? Again, they're called premature complexes. And so, so the best way to think about this is, all right, so these are your normal complexes here, right? Just QRS complexes that you see. Normal QRS complexes. When it's premature, so before you go from this beat to this beat, or squeezing of the ventricles, if you will, a premature complex is going to pop up here, or pop up here, or wherever. Right? So basically, they are what we call early rhythm complexes. And the problem with them is that they don't produce or generate a pulse, a perfusing rhythm. So the reason this happens is when a cardiac cell or a cell group or other SA node becomes irritable and it fires an impulse before the next sinus impulse is produced. So remember I told you within this tissue, or even the SA node for that matter, if it becomes irritated for whatever reason, sometimes it could be due to electrolyte issues, medications, or otherwise, but when it becomes irritated, it fires off one of those premature beats. All right, so that's what's really happening. But it can occur from any of these sections in the actually it can occur in the SA in the atrial tissue, junctional tissue, and the ventricular tissue as well. When you see these strange looking beats, we call them an ectopic focus. So these impulses are just coming from different areas. This ectopic means abnormal. So for example, we might say the patient has normal sinus rhythm with ectopy. And when we say with ectopy, again, we mean there's an abnormal rhythm that may pop up somewhere before the actual normal sinus beats or sinus impulses. So it's referred to as an ectopy, an abnormal focus or beat. Now, what typically happens after this premature complex, it leads to a pause before the next complex. So when you have that bizarre rhythm that takes place, there's a pause. And again, so if there's too many of these pauses, it can lead to an irregular rhythm. And of course, this can cause the heart not to beat normally. And then, of course, these patients, they have their cardiac output is compromised at that point. Now, these patients, they have a sensation. They may have palpitations, or it feels like their heart is skipping a beat, that type of sensation. So when these when ectopies are occurring, the patient may report that to you, or you might, doing your history and physical interview with this patient, they may express to you as a subjective complaint that, yeah, my heart feels like it's skipping a beat. So if they put them on an EKG monitor, you might see, if it's going on currently, you might see these extra beats, these extra complexes, these bizarre complexes. Now, most patients are able to tolerate them. However, when the premature beats or complexes come from downstairs or within the ventricular tissue, that's when you can have a problem. More so, you can have a problem when they originate downstairs than upstairs. And just like someone mentioned earlier, yeah, because the ventricles squeeze blood, especially on the left side, throughout the systemic circulation. And so this is when these ectopic beats can become a problem. It reduces the cardiac output. And so you have those, again, what? Classic symptoms. All right, so that's what the issue is with this. That cardiac tissue, it just becomes irritated, and it'll throw a beat out there, and they may not be perfusing beats. This slide you're looking at now, these are, for the most part, perfusing beats, unless this was PEA. Because it could look like this, but it's PEA, meaning you have an electrical rhythm, but no pulse or blood pressure. Right now. So let's touch on, before I go further, any questions on what I just discussed?
No.
Pretty simple, eh? At least I hope it is. All right, so now let's get into our Brady dysrhythmias, meaning our slow abnormal rhythms, or tachydysrhythmias, our fast rhythms, right? Now, as far as the Brady dysrhythmias, the heart rate will be less than 60 all the time, because the definition of bradycardia is a heart rate less than 60, and the definition of tachycardia is a heart rate greater than 100. Now, this rhythm can be, as far as the Brady dysrhythmias, this rhythm can be significant due to, so if it's not beating too fast, then the heart muscle doesn't demand as much oxygen because it's not beating that fast. So to a point, it can be beneficial because, if it's beating really fast, then it requires more energy, more oxygen. But in this case, if it's beating a certain rate, which is below 60, but not too low, again, it can be beneficial. Why? Because with Brady arrhythmias, you get more relaxation of the ventricles. And when the ventricles relax long enough, not too long, but when it relaxes long enough, they can fill with blood a whole lot easier. So you get an adequate filling of blood. All right. You get that prolonged diastole, which can be desirable. The flip side of that is, if the heart rate becomes too slow, so when it's too slow, coronary perfusion pressure begins to decrease. for a heart rate that is too low. And if the heart rate is too low to the point where the patient cannot tolerate it, then it becomes a problem with the cardiac output and the blood pressure. Because when the cardiac output falls, so does the blood pressure. And this can have some pretty significant complications because if the cardiac output falls, then your vital organs and tissues do not receive adequate blood flow, nutrients, oxygen, vital minerals, and so forth. So that's when it becomes dangerous. When it's too slow, you lose that coronary perfusion pressure, and then meaning you lose your heart rate, your blood pressure, and then you have those classic symptoms of poor cardiac output. Remember that priority concept of perfusion. All right. With that, your vital organs and tissues starve to death, if you will. So Brady dysrhythmias can be tolerated as long as the blood pressure is normal. But when the blood pressure becomes abnormal, meaning now you're not perfusing even your myocardium, because remember, off of the aorta, some of those arteries run right back into the heart. And so if you're losing your blood pressure, your cardiac output, then you're not even perfusing your cardiac muscle. And so these patients experience myocardial ischemia, meaning they're still getting some blood, but and it's insufficient amount. It can also lead to a myocardial infarction when they're getting hardly any blood flow at all. It can lead to a dysrhythmia because if you don't perfuse your coronary, or if your coronary arteries are not perfusing your conduction system, electrical conduction system, then you will see those abnormalities. You'll see also a low blood pressure. You'll see heart failure because if it's a poor cardiac output, that blood has to go somewhere and it's going backwards. Heart failure, in other words. See, many of these abnormal cardiac problems, they can lead back to heart failure, which is why it's so important to understand heart failure. All right, so that's tachycardia. Brady dysrhythmias. Now, tachydysrhythmias, again, it is a heart rate of greater than 100, and it is of a great concern for those patients who have coronary artery disease. All right. Now, so the question becomes, when does coronary artery blood flow occur? When do the myocardium receive its blood supply? And it's mostly during diastole, when the ventricles are resting, believe it or not. That's when the coronaries are being perfused. And the aortic valve is closed. And so this is determined by the diastolic time and also the blood pressure as well. Now, your tachydysrhythmias can be serious because when the heart is beating really fast, just going beating, the diastole time is short. And if it's short, then you're not getting or receiving enough blood in your ventricles, and not having enough blood in the ventricles means that less blood is pumped out into the systemic circulation. And so your perfusion is decreased. So you have very little blood flow going to the coronary arteries, meaning the muscles become compromised in the conduction system of the heart and also the rest of the body. You need adequate resting time diastole, and you need an adequate squeezing systole. All right. Now, with the tachydysrhythmia, when the heart is beating very fast, initially, you have an increase in your cardiac output and also your blood pressure. So you're getting a good cardiac output, blood pressure for a moment. But as I mentioned, when your heart rate is too fast, you get a reduced ventricular filling time, which means your heart is not resting long enough. And if your heart is not resting long enough to fill adequately, your stroke volume is going to be down. Remember, stroke volume is for every beat, you're pushing out between 60 and 100 cc's of blood. But it becomes reduced because you're not filling those ventricles because the heart is beating too fast. And after a period of time, because this doesn't last long that you get that good cardiac output, so after a period of time, the cardiac output and the blood pressure will now begin to decrease. Then you have this reduced aortic pressure. And then you have this decrease in your coronary perfusion. Again, meaning your coronary arteries are perfusing less blood because you're just not getting enough. The heart is just beating too fast. And the rest of the body is not getting enough. When the heart is beating very fast like that, it leads to what we call increasing myocardial oxygen demand. In other words, it's beating so fast that the heart is requiring more oxygen. That's not good for the heart. All right. Now, signs and symptoms of a very fast heartbeat or your tachydysrhythmias is palpitations, chest discomfort, myocardial ischemia and infarction, restlessness. Well, let's see, up to that point, actually, they're similar to your sinus bradycardia. Again, it's because you're not getting good perfusion. But then in addition to that, you have the restlessness, anxiety, pale, cool skin, syncope. They black out from what? Hypotension, because you're not getting enough blood flow to your brain. Your blood pressure drops, you're not perfusing your brain, you fall out. You have pale, cool skin because you're not perfusing a good blood flow to your skin, also to your muscles. You get weak, you have cool, pale skin. Now, when the heart is beating really fast like that, it can lead to heart failure because the blood, it can't, you're not pushing it out enough so that it backs up. And these patients may go into heart failure. And they may exhibit signs and symptoms of shortness of breath, lung crackles, distended neck veins, fatigue, and weakness. Remember, we're going right back to heart failure. That's why you need to know heart failure. All right. So tachycardia occurs when an abnormality in the heart produces rapid electrical signals that quickens the heart rate, makes the heart rate really fast. We know the heart rate is normally between 60 and 100. If this is left untreated, tachycardia can disrupt the normal heart function and lead to serious complications, including heart failure. So when the electrical system is beating too fast, or rather when the electrical impulses are sending impulses too fast, the heart muscles will respond in kind. And they will beat really fast as the electrical impulses can travel or can fire off, the heart muscle is responding to that. So if it's a fast rhythm, fast heartbeat, if it's too fast, those ventricles cannot fill properly. You don't have enough volume of blood in the ventricles to be pushed out into the systemic circulation. Classic symptoms of heart failure, of low cardiac output. Does anyone have any questions? Actually, I got that on the wrong one. Sorry about that. That was on the wrong one. Let's see. Yeah, we were here. So we just got through talking about bradydysrhythmias and tachydysrhythmias. So quickly, when you guys are, when you go into your clinical at 12:30, my plan is to have you guys do one concept map, and I'll show you how I want you to do it. And I just want to give you one because I know that you have a test with Professor Thody on tomorrow. And you don't have to say who you are, but there's someone on here who has to talk to Professor Thody tomorrow. It was supposed to be today, but I don't think you or I realized that we had to be in class from 8 to until 5. So if she didn't contact you yet, then she said that she'll meet with you tomorrow. So you don't have to say who you are. Just kind of throwing that out there. So we will be doing a concept map, and I'll show you what I need you to do with that. And I won't make it too tedious, but I wanted to be done right, if you will. Let's see. All right. Now, so we talk a little more about sinus. Well, we talk about sinus tachycardia, which is a tachydysrhythmia, and also sinus bradycardia, which is a bradydysrhythmia. And again, we know with tachycardia, the heart rate is greater than 100, and bradycardia, heart rate is less than 60. Now, typically, when we treat sinus bradycardia, a slow heart rate, we treat the underlying cause. So say if the underlying cause is due to some medications. So we'll DC the medication or we'll titrate it. But the way we treat it is we give these patients IV atropine 0.5 milligrams. This is distinguished from when we treat some other patients who have symptomatic, the ACLS algorithm, I guess I should say. We usually treat them with 1 milligram of atropine, but with your sinus bradycardias, typically in this case, we'll just treat it with 0.5 milligrams of atropine, and this will increase the blood pressure, the heart rate. We also will give them IV fluids because the IV fluids will put more volume into the vascular or intravascular space, your blood vessels, your arterial blood vessels. And what this would do is it will increase your blood pressure because remember, these patients lose their blood pressure. So the volume increases the blood pressure, the atropine increases the heart rate, and the oxygen is needed, the O2 is needed, because remember, with a low heart rate and a low cardiac output, these patients are not perfusing enough blood which contains the oxygen. So we want to give them more supplemental oxygen to help in this effort. And as I mentioned already, we want to DC medications that may cause sinus bradycardia. If a patient ODs, overdoses on beta blockers, we give them the antidote glucagon, and this will help to increase the heart rate and the blood pressure. Now, if these conservative treatments that I just mentioned are unsuccessful, then we want to prepare for what we call transcutaneous or transvenous pacing in order to increase the heart rate. When we say transcutaneous, we'll put a patch on the patient's chest wall, and it will deliver electricity to the patient's myocardium, giving them a better heart rate. If it's transvenous, then we'll insert an IV. It's like a special IV with a pacemaker on it, which will go, it'll be inserted all the way up into the right atria. And then those probes will stimulate the heart to beat. And so you get a heart rate depending on where you put the settings. All right. When a patient when they're receiving this kind of therapy, it's very uncomfortable and it's very painful. And so what we typically do is we give them pain medications, and we also give them a sedative, help them sleep. Again, it's very uncomfortable. Now, there are times the pacemaker fails, and so we may have to insert a permanent pacemaker. And there's a section in this slide that does talk about the permanent pacemaker. So there's a lot of information, not a lot, but there's a fair amount of information for you to understand about that. Before I go further, does anyone have any questions?
I do not.
All right. Again, stop me if need be. All right, and as you guys can see, I'm being very deliberate and not going too fast, but I do, if I don't finish this particular slide, I have finished it on another voiceover, so, but we'll get as far as we can, and I'll also upload this one as well. All right, so the SA node, sinoatrial node, is located in the right atrium, and it is the pacemaker. In all sinus dysrhythmias. So if there's a sinus dysrhythmia, that's where the problem is. Now, the SA node can be affected by the sympathetic and parasympathetic nerve, because both of these nerves are connected to the SA node. Is connected in order to ensure some kind of balance. So say, for example, if you're getting ready to run from a dangerous situation, the sympathetic nervous system will stimulate the pacemaker to increase the heart rate. Why does it increase the heart rate? Someone. You're trying to run. Why do you need an increase in heart rate?
So your body is.
Let's say again.
So it could perfuse better.
There you go. There you go. See those muscles in your body and and those muscles and everything that requires, you know, a quickness and to be able to get out of the way and to move, even exercise. Anything that is physiologically demanding, you need an increase in heart rate so you can get better perfusion to those organs and tissues. Now, once that activity is done, your parasympathetic system kicks in, which is the opposite of the sympathetic. Remember, the parasympathetic is your rest and digest. The sympathetic nervous system is fight or flight. And so that's why the parasympathetic and sympathetic nervous system innervates or it stimulates your pacemaker, because depending on the situation, you may need an increase in heart rate, or the opposite occurs where the parasympathetic nervous system brings it back down to normal, because you don't want to stay in that fight or flight forever. You can't. Physically, you can't do it. All right. So, and also there can be it could be a physiological change, a normal response. I mean, it doesn't always have to be pathological. So, but just know that it can be affected by the SA node, by the sympathetic and parasympathetic nervous system. Now, sinus tachycardia and your bradycardia are two of your most common types of sinus dysrhythmias. They're the most common that you'll see. All right. So you have sympathetic nervous system stimulation that I mentioned, but you also have parasympathetic inhibition because it kind of pulls it back. It stops the sympathetic stimulation. We call that a vagal response. All right. So sympathetic would cause an increase in heart rate. Parasympathetic causes a decrease in SA node discharge. And so you have either increased heart rate, low heart rate. So this is why when you have a patient who is having a bowel movement or anything that causes bearing down and straining, you're stimulating the parasympathetic nervous system, that vagal response, and sometimes patients can actually lose their heart rate because of that. And this is why we admonish or we encourage our patients, we teach them not to bear down, not to strain. And for that reason, we don't, if they constipated, for example, then we want to, these patients should be advised to get on stool softeners so they don't have to strain. Now, with sinus tachycardia, all right, so normally the heart rate doesn't exceed 100 beats per minute, except in response to an activity, which can increase your heart rate to as much as 160 beats per minute. Typically, it's rare that your heart rate will go greater than 180, but I have seen it, especially in a spin class. My spin instructor, I think her target heart rate is around 190 or something like that, and she gets up there, she stays there like consistently. So on the heart monitor for her, it always stays in the red. Now, sinus tachycardia initially will increase your cardiac output and your blood pressure, but if it continues, again, as I mentioned, it will lead to a decrease in coronary perfusion time, diastolic filling time, as well as your coronary perfusion pressure, and it would cause the heart to have to work a whole lot harder, and you don't want that. Now, an increase in sympathetic stimulation normally is in response to physical activity, but it can also be caused by, or it can be caused by if somebody has anxiety, that stimulates your sympathetic nervous system, pain, stress, fever, anemia, hypoxemia, and also hyperthyroidism. This can stimulate the sympathetic nervous system. Now, due to the possibility of this decreased filling time when the heart rate is too fast, these patients have poor perfusion to the cardiac muscle, and it can cause chest pain. The chest pain is due to a lack of blood flow to that area. Now, drugs can also cause an increase in heart rate, for example, epinephrine. And sometimes from a therapeutic, therapeutic wise, we may want an increase in heart rate or an increase in someone's blood pressure. So we give them epinephrine, or we may give them atropine because the heart rate is too slow. But then some patients may also take caffeine, alcohol, nicotine, as well as cocaine, aminophylline, which is what they give asthmatics in order to dilate the bronchioles. And also thyroid medications can also increase the heart rate. So we always want to look at those drugs and patient's lifestyle, because we may have to educate them about reducing caffeine, alcohol, nicotine, especially cocaine. Now, sinus tachycardia can be a compensatory response to decreased cardiac output or blood pressure, as occurs with patients who are dehydrated, patients who are in hypovolemic shock, people who have had an AMI, an infection, as well as heart failure. Remember in heart failure when we talked about the compensatory mechanism wherein the body organs and tissues sense that there's a decrease in perfusion, and so it will cause the heart to beat really fast. Of course, this is when we give these patients beta blockers. So these are conditions where the heart rate will be increased. Remember how you probably learned that when someone is in shock, their heart rate is increased, but their blood pressure decreases. Let's say if someone is hemorrhaging or they're severely dehydrated, because they have a low volume, intravascular volume, the heart will increase in order to, as a compensatory mechanism, to increase the cardiac output to get as much blood to the vital organs and tissues. That's a compensatory response. All right, and it's not always good. Now, patients with signs and symptoms of hypovolemia, meaning very little blood flow in the vascular system, or dehydration, they can experience orthopnea, meaning when they lie down flat or in supine position, they have difficulty breathing. They experience restlessness and anxiety because they have this impaired perfusion to the brain, not getting perfused. There can also be a decrease in O2 saturation because, again, you're not getting good perfusion, so your O2 sats are going to be low, not getting good exchange of gas, O2 and CO2, namely O2. There's also an increase in your heart rate because that's the compensatory mechanism that's at play. You also have a decrease in urine output. Why? Because there's a decreased perfusion of blood to your kidneys. The blood pressure falls. It decreases because the vascular compartment or space is depleted, not depleted completely, but there's a reduction in the amount of volume in the vascular space, so the blood pressure is lower. And dry skin and mucous membrane, because if you're dehydrated, of course, then you don't produce the moisture that you need for your skin and mucous membrane. So as far as treatments are concerned, the key is to lower the heart rate to normal by treating the underlying cause. Let's say if the underlying cause is pain, give them pain medication. Underlying cause is because they're intravascularly depleted because they've been outside in the sun for a long time, cutting the grass, cutting down trees, doing this and doing that. You give them IV fluids. If someone has a fever, you give them something to reduce the fever, right? So you're just treating the underlying cause, whatever that is. If increased heart rate causing hypotension and weakness, or if it causes hypotension and weakness, those patients should remain on what? Bed rest. Because they get up walking about, they fall and injure themselves. As far as patient teaching, we want to avoid substances that increases the heart rate, such as caffeine, alcohol, and nicotine. So we have to teach that to our patients. This is the health promotion and maintenance piece that is on your NCLEX. We must know these disease processes so we know what to teach our patients. We also want to teach stress management strategies because stress can also alter the heart rate. So we might refer these patients to a mental health provider. Any questions about sinus tachycardia and its treatments and so forth? All right.
I actually understand it better. Thank you.
You understand it better?
Yes, I do.
Good, good. Yeah, I'm trying to slow down and really break it down. So because if I go too fast, you guys are going to resort to memorizing. But if I make you understand it, we won't have to do all that. Not a good thing. So sinus bradycardia, we know it is a heart rate of less than 60. We know that the parasympathetic nervous system can stimulate the pacemaker to decrease the heart rate. So there's a low SA node discharge. And of course, now when we talk about excessive vagal stimulation, that parasympathetic response, it can happen for several reasons. It happens with carotid sinus massage. You know, when you see them massaging the sinus, the carotid sinus area, because what they're trying to do sometimes with these particular procedures is to lower the heart rate. It can also occur, or this vagal response can occur if somebody is vomiting, you know, because you're kind of straining and you're bearing down. And also with suctioning, if you suction your patients too long. So be careful about suctioning your patients. Also with Valsalva maneuver, which means bearing down for bowel movement or gagging, this can also stimulate the parasympathetic response, a vagal response. Also, if you're pressing on eyeballs, which we might do if we're trying to lower the heart rate. Pain also, because you're not breathing, you're bearing down, you're straining, right? So all these are vagal responses that can stimulate the parasympathetic nervous system. So again, these patients must avoid straining. So you give them stool softness. Now, increased parasympathetic stimuli, what can stimulate the parasympathetic nervous system? It can be due to hypoxia, an inferior wall MI, drugs such as beta-adrenergic blocking agents, calcium channel blockers, and digitalis. All right, so we always want to, again, check those drugs. Give these patients the oxygen they need. Make sure you're monitoring their heart rate when you're giving them beta blockers. If it's too low, don't give it to them. Of course, you have to call the physician to inform them. Now, other causes of low heart rate is Lyme's disease, electrolyte disturbances or imbalances, neurological disorders, hypothyroidism. And so you always want to make sure you ask patients what medications they're on, because some medications, again, will reduce your heart rate. Now, let's see. Remember I talked about some of these patients who may have a low heart rate, even as low as 30. Your athletes who are in very good shape, and they have what we call a hyper-effective heart. It's due to the fact that their heart muscles are so strong, when they squeeze, they get inadequate stroke volume, even with a low heart rate, but they do have a normal cardiac output, so they're usually fine. Now, remember I told you with sinus bradycardia, you can lose your blood pressure and your cardiac output. And so these patients get a lack of oxygen to their brain. And so they can experience syncope or fainting, or they can black out, basically. Dizziness, weakness, again, poor cardiac output. Confusion, poor cardiac output to the brain. Low blood pressure. They become diaphoretic or excessive sweating. They become short of breath, and also chest pain. Now, again, sometimes these patients can tolerate their sinus bradycardia. So if a patient is in sinus bradycardia, or even in sinus tachycardia, and they're not displaying any symptoms, we just monitor. Because in this particular case with the sinus bradycardia, the only symptom is a low heart rate. Now, most cases of sinus bradycardia, we don't know why. So, but we do want to check the MAR because we want to check to see if there's any medications that might slow the conduction electrical conduction through the SA-AV node, such as your calcium channel blockers, beta blockers. Now, your slow channel blockers, they tend to inhibit the slow inward calcium current, because you know the electrolyte calcium, when it flows into your cardiac cells, it causes good contractions. But if you place somebody on a slow channel blocker, then it can prolong the conduction, so they have a slower heart rate. All right, so check those medications is what I'm saying to you. Now, calcium channel blockers. So by blocking the entry of calcium into the cells, so the calcium channel blockers, they reduce also the electrical conduction within the heart, as I mentioned. Now, this would decrease the force of contraction, so the heart muscles won't contract as well. But the coronary arteries, they will dilate, right? When those arteries do dilate, the blood pressure will drop. All right, and it'll reduce the amount of pressure the heart has to pump against a lot of pressure, so it does reduce your afterload. That's why they give these patients calcium channel blockers, especially in African Americans who cannot tolerate ACE inhibitors. They may put them on a calcium channel blocker, which will dilate their blood vessel, decrease the blood pressure, and the left ventricle works less hard against the afterload. And we must not forget preload, afterload, and contractility as I think about it. With the low heart rate, we already talked about the different types of pacemakers. It might have to go to a permanent pacemaker. I do have information in there about that. Now, how a pacemaker works is that the electrical stimulus is spread throughout the heart in order to depolarize the heart cells. And that's what causes the heart muscles to contract. And if you get a good contraction from this electrical activity, which is very uncomfortable, as I mentioned, it can produce a good cardiac output. And so that's how that works. It stimulates the cardiac cells, that electrical activity. All right. So again, these patients may require pain medications and sedatives in order to tolerate the electrical stimulation. But both of those types, the transcutaneous and transvenous, they are temporary. But the pacemaker you see beneath the skin, when you see that little box or elevation in the skin, that is the permanent pacemakers. So that's a lot when it comes to treatment, signs and symptoms, and causes of sinus dysrhythmias. So now at this point, my voiceover will start, but since we have a little more time, I'll keep on going. There's a voiceover I have that continues this discussion again, but since we have a little time. So this is a sinus tachycardia. The heart rate here is 110 beats per minute. And look, that is, it's not a normal sinus rhythm, but it is a sinus tachycardia. It does originate in the upstairs or the atria, because that's what we're talking about. This is sinus bradycardia, and it originates in the atrial, the sinus area, you know, sinoatrial node. So it originates in that area. So it's sinus bradycardia. They might tolerate it, maybe not. Very important information here, because you will have a lot of patients who have this pacemaker. You see this pacemaker here? And so you see this depiction, but obviously you know that skin normally covers, skin does cover this. So you won't see the generator, not in this way, but you will see the bulge. And this is where these leads from this pacemaker, one attaches to the atria and one attaches to the ventricle. And because of this, we call it, when we see these spikes, which I'll show you these spikes on an EKG rhythm, we would call it an AV spikes. And it means that the the atria and the ventricle are being stimulated by the pacemaker. Sometimes it's just a ventricular pacemaker, meaning there's just these leads are attached to the ventricle or stimulates the ventricles, and it causes it to beat. All right, gives you a heart rate, and they can set it at a certain number. Let's say 70 beats per minute. If the pacemaker is working, then you'll see 70 beats per minute. If it falls below that, then it's probably not capturing, so your heart rate would be lower. So you should see these, what we call pacer spikes, before either a P wave or a QRS complex or both. And this indicates that the atria and the ventricle are being paced. If not, we must monitor the patient's vital signs and their level of consciousness, because, you know, if they're not being perfused, then they'll lose consciousness. And real quickly, let's see. See if this will show me one. So I think this is a good one. Let me share this one again. So remember that picture I showed you with the pacemaker. If you have a lead in the atria and also the ventricles, on an EKG rhythm, you're going to see a spike before the P wave. You know, remember the P wave represents the atria, and you're going to see a spike sitting just before the QRS. And we know that the QRS complex correspond to the ventricles. So you see two spikes. See these two spikes. Sometimes you might lose these spikes, and it means that it's not capturing. So it could result in a poor cardiac output because it's not stimulating the heart muscle like it's supposed to. This pacemaker is taking over the function of your heart's normal conduction system, by the way. It's replacing it because for whatever reason, the conduction system of your heart is not working well. All right. So you have these spikes, and it helps to stimulate both the atria and the ventricle. Now, sometimes you just have a spike, or you have a ventricular or just an atrial pacemaker. So if it's an atrial, then you'll just see one spike before the P wave, but not the QRS. If it's a ventricular pacemaker and not atrial, if it's not an AV pacemaker, just a ventricular pacemaker, you'll see just one spike before each QRS. Before each QRS. Make sense? So this is an example. You see how this spike is before this QRS? So this is a ventricular pacer. This is not an AV pacer because you don't see a spike before the P wave and the QRS. Well, you have one before the QRS, but not both. It's just before the QRS throughout, not AV. There's an AV and there's a V. I think there's an atrial pacer as well. All right, and so it's just taking over the normal function of the conduction system. Can you all see my pacemaker PowerPoint?
Yes, sir.
All right.
Yeah.
All right. I didn't know if I had to redo it again. Let's see. I did provide some links in here, but I'm not sure if they're still working or not. Actually, I can test them because I wanted you to look at some of these links, but I don't think they're working anymore. All right, so these videos are not available anymore, so just kind of ignore them for the time being. Actually, I'm gonna make them really small. All right, so just ignore them for the time being. Now, when it comes to a pacemaker, education is very important. So when someone has a cell phone, we want to keep the cell phone about 6 inches from the generator itself. So if a pacemaker is on the left side of the chest wall, then we put the phone to the right side, about our right ear, the opposite side of the generator, because the pacemaker can mistake interference from the smartphone's electromagnetic field for a cardiac signal. So that can disrupt the pacemaker and cause the heart to beat irregular. So it can trigger your ICD to shock your heart. Some of these pacemakers have an ICD and pacemaker. They're both. ICD is an internal cardiac defibrillator. So if a patient goes into VTAC or ventricular fibrillation, they'll get a shock. Just like that defibrillator I showed you earlier, some of these pacemakers have both types. And so if it senses an abnormal or lethal rhythm, such as ventricular fibrillation, it'll shock these patients. But it also, so it has a dual function. It also controls the heart rate, but it shocks the patient as well. You also want to avoid strong electromagnetic fields like magnets and telecommunication transmitters. They can interfere and change the pacemaker settings. And so it causes them to malfunction. You also want to avoid going into MRI devices, depending on the technology in most cases. So you must, those who are performing these tests have to be informed. The physician may not even order it if he knows that they don't have the technology that can avoid impacting the pacemaker.